I think we would all argue that a patient who is a transplant candidate is going to get a second-line chemotherapy regimen, whether it's RICE or RGDP or one of the other platinum-containing regimens. Certainly, if they have a CR, they're going to go on to get an auto transplant as of today. There was some data presented at ASCO suggesting that even if they just had a PR, they could do well with an auto transplant. I think that's an area where there's some has been some uncertainty, and maybe we'll come back to that in a few minutes. But certainly patients who get an auto transplant and relapse or are multiply refractory, CAR T cells have become, assuming the patient's a candidate, have become kind of the standard approach. So I'm going to ask you, Matt, to give us kind of a brief summary of the three leading agents in this setting and kind of how you think about them, and then we'll come back to some of the new data presented at ASCO and otherwise. So how do you think about CAR T cells, Matt?
Yeah, so I'll rewind a little bit. You know, when I see that primary progressive or primary refractory patient or frontline setting that is transplant eligible, I'm already starting to, you know, discuss CAR T cell therapy at their initial visit, because, you know, while they can go on and get second line platinum containing regimens, I still think that there's a high probability that they're not going to have chemosensitive disease, that I'm going to want to take them down the path of a consolidative transplant. And so kind of CAR T cell is such a complex process that if you just wait till 2 to 3 cycles of second line therapy and then drop that, you know, discussion in, you know, it can leave their head spinning. Plus, there's a lot of, you know, just like there's a lot to get into doing a transplant, there's a lot of logistics to do a CAR T cell. And so having already started that process, or having people aware that you could go down this road, you know, when that PET scan occurs that doesn't show that a response is amenable to consolidative transplant, you can quickly pivot to CAR T cell. And I think that that's the important part, you know, and that's what we're all preparing for, both in the commercial setting and previously in the clinical trials. Right now, there are 2 commercially available CD19 directed CAR T cells, axicabtagene and tisagenlecleucel. You know, they both have had single arm data, both with the ZUMA-1 trial as well as Juliet. Lisocabtagene is in late stage development, been presented multiple times, yet to be published from the Transcend data. You know, all in all, when I describe them as all 3 apples. They're not apples and oranges, but they're apples, but they're 3 different types of apples. You know, they could be Fuji apples, Red Delish, and Granny apples. But they do have their, you know, their subtleties to them, just like each apple may taste a little bit differently. You know, but they're still apples. If you look at the response rates, you know, the overall response rates are on average 70 to 80%. Their CR rates are anywhere from 40 to 50%. You know, their PFS actually line up. Their median PFS are right around 6 months. So there's still a lot of patients post-CAR T cell that are progressing. But on the flip side, there appears to be, you know, durability. So if you can get to CR in 6 months, you know, there appears to be, you know, 30 to 40% of the patients that may derive, you know, benefit, and to the point where you're just starting to discuss that this is, you know, now 3 chances to cure diffuse large B-cell lymphoma up front, after an auto transplant, and potentially after CAR T. So for those double refractory patient populations, if you have your ducks in a row, you can get that narrow window of kind of disease stability and going to a CAR T cell. You know, so, but you have to be, you know, previously treated with two lines of therapy to get a commercially available CAR T. I still think there is room for improvement in clinical trials in CAR T from that standpoint.
So from the available or close to available agents, what's kind of your quick and dirty bottom line? I know there are a lot of researchers, a lot of studies trying to compare apples and oranges. To me, it seems like they're more similar than they are different, but you know, they're the key distinctions, at least from the clinical perspective.
I tried to get the CAR T cell that I know when I apheresis, that I know that is coming back and I can infuse it. I think we've gotten better, you know, over the last about 5 to 6 years now that we've been trying to manage toxicities. I think we've gotten better at managing toxicities, and we're looking at strategies to manage toxicities better, to try and prevent those grade 3, 4 CRS and neurologic events, but being mindful that you don't want to affect the efficacy of the therapy by the risk mitigation strategies that you're using. So right now, getting it out and getting it back in the shortest period of time, because large cell lymphoma doesn't care that the coronavirus is going on. It doesn't care that's the weekend, and it doesn't care it's a holiday. It's going to grow. It's going to grow. And at least what the data is showing us is that bulk matters, LDH matters, and you don't want to AFE and not infuse.